So I'm going to talk this morning about pancreatic cancer screening to kind of summarize some of the stuff that's already been said, and then talk also about other issues relating to pancreatic cysts per se. I'm just going to start with a case. This is a 50-year-old lady who had 3 distinct attacks of recurrent acute pancreatitis, underwent a variety of evaluations, including good quality CT scans and MRI scans, and nothing was found. She subsequently came to us for an evaluation with an endoscopic ultrasound. If we can just show this down here. And by and large, most of the pancreas was normal. But after kind of ongoing interrogation, there was kind of a small 5-millimeter area that was suspicious that we biopsied. And the cytologist said there's something concerning going on there. And that was enough for her to be very concerned based on what was going on and to want it removed. We ended up having to tattoo the area because she wanted to remove laparoscopically, and so we actually placed a tattoo nearby the lesion, and she subsequently underwent actually a distal pancreatectomy laparoscopically. And the final diagnosis was of actually an IPMN with high-grade dysplasia, no cancer. And so this is going back several years. This is 2006, and you can imagine she's actually done remarkably well. So this is like a poster child kind of for early detection, but in a symptomatic population. And unfortunately, for a lot of pancreatic cancer screening, we're dealing with much kind of, not often as much luck per se, and lots of questions in terms of like, what should we be screening for, who should we be screening for, when should we start, what should we be screening with, when should we stop screening, what's defined as a successful screening program. And so just to kind of bring your kind of focus in on this particular area, even on the question, what should we be screening for? We think pancreatic cancer starts in terms of individuals having what's called a KRAS mutation, and then a series of events going through pre-invasive steps that for pancreatic cancer are called Pannin lesions, Pannin 1, Pannin 2, and Pannin 3, and then ultimately developing into pancreatic ductal adenocarcinoma. And this is kind of the common sequence that's seen for pancreatic ductal adenocarcinoma, and these are some of the pathologies associated, and some of them can only be seen microscopically. In addition then, we'll talk about this later, but there's another similar sequence of events that leads to cysts or IPMN that have another related malignant degeneration associated with them. So a recent consensus guidelines came up with the suggestion that a successful screening program should detect and treat, for sure, early stage negative margin pancreatic cancers, and particularly patients who are asymptomatic because they seem to do better, but also, if possible, high-grade dysplastic precursor lesions, such as these Pannins, as well as IPMNs and MCMs. Now, one of the questions is, how do we do this? And wouldn't it be great if we just had a simple blood marker? And it isn't for the lack of trying. This is just a short list of many, many studies that have been ongoing, looking at a variety of markers, including, for example, we mentioned CA19-9 earlier on for the diagnosis of pancreatic cancer. And it's got, okay sensitivity, doesn't pick up all the cancers, and it doesn't have great specificity, meaning it actually has a lot of false positives as to certain benign diseases that it shows up on. Now, there was some hope earlier on this month when this publication came out, and this was alluded to earlier on in Dr. Rish's study. So this is the CancerSeek study, and claiming a single blood test for 8 cancers, $500. And it actually included over 1,000 cancers of 8 common types of cancers, including 92 patients with pancreatic ductal adenocarcinomas. All the patients included at early resectable stages, and the panel includes a blood test looking at 16 genes as well as 8 proteins. And it was said that for pancreatic ductal adenocarcinoma, the sensitivity is 70%, so it's picking up 70% of these cancers with this whopping specificity of greater than 99%. And there were some false positives. It also went on to say that it could help localize, so if you had a positive test, you could actually go back and say this is coming from the pancreas. And so while that sounds impressive, one of the problems is that actually it's not impressive enough, and it's just where these tests unfortunately fall down. So for general population screening, one of the concerns we have is the generation of a lot of false positive tests. And so telling patients, hey, I think you might have a diagnosis of cancer, but we're just not sure. We have to do more testing. And most of them actually turn out to be cancer. And this has to do with how these biomarkers and their operating characteristics function. So a positive predictive value, if you just focus on that, is what happens in the real world with the general population if you say a test is positive, how often it actually turns out that that patient will end up having cancer. So if you look over here on the left-hand side, this is dealing with very good sensitivity, anywhere between 0.9 and 0.999, and a specificity of 0.9. And the positive predictive value is less than 10%. So less than 10% of patients will end up actually having a malignancy. Even if you increase the specificity, and you get the specificity up to 0.99, now the positive predictive value has only gotten to about 20%. So there's real challenges here when dealing with the general population for screening. And as a result of that, it's the reason why a lot of us have focused on high-risk groups, groups of patients that are enriched for the development of pancreatic cancer. I won't get into diabetes, it's already been discussed, except to mention an ongoing clinical trial headed by Richard Frank, who's here in the audience, at the Western Connecticut Healthcare Group, that's hoping to include many more sites around Connecticut and the Northeast. We will spend some time, however, talking about familial pancreatic cancer, which accounts for about, as you've heard today, accounts for about 10% or so of patients with pancreatic cancer. This list you've already seen, but I want you to focus down on, again, this entity of familial pancreatic cancer. And what that defines as is families that have at least 2 or more first-degree relatives with pancreatic ductal adenocarcinoma. As was already alluded to, the more family members you have, the increased your relative risk. And still to date, even though there are these obvious family kindreds, the most common genetic abnormality that's found in these groups of patients is still only the BRCA2 gene, and we're still trying to figure out the genetics associated with familial pancreatic cancer. So who in 2018 then undergoes pancreatic cancer screening for familial risk? We certainly look at patients with Peutz-Jeghers syndrome, beginning at the age of 30. Individuals with familial pancreatic cancer kindred, so these are, again, greater than 2 first-degree family members related to each other, beginning above the age of 55 or 10 years younger than the youngest affected family member, are typically enrolled in these studies. We then look at a variety of germline mutation carriers that have at least one familial member with pancreatic cancer. These are in 2 broad groups. There's a high-risk group that includes P16, BRCA2, PALB2, and ATM, and then a slightly lower risk group that includes BRCA1 as well as HNPCC, or the Lynch syndrome. The hereditary pancreatitis group is also included in screening protocols. This is what we do in our own pancreatic cancer screening research protocol, which is the CAPS-5 study. Patients are typically seen by the Cancer Genetics Counseling Group. Blood is collected for research. Patients have a high-quality MRI scan and then undergo endoscopic ultrasound. And this has been done time over. This is not, per se, an unusual or novel particular approach to doing this. And this is a summary of a variety of the studies that have been done for pancreatic cancer screening over the last couple of years, looking at a variety of enrollments, different disease states, using combinations of endoscopic ultrasound and MRI as well to look, and a variety of outcomes. And kind of, we quote a diagnostic outcome of anywhere between 2 to 40%, meaning sometimes an incident cancer is found, or sometimes an incident endocrine neoplasms, sometimes incident IPMNs or cysts are found. And interestingly, under certain circumstances, these Panin-3 lesions, these early pre-invasive lesions, have been found. But the big challenge with all of this is still to prove an impact on survival. We're finding things in these screening studies, but the question is, are we actually impacting large groups of patients that we are screening? One interesting aspect of this particular study is the ability to collect pancreatic juice at several time courses throughout surveillance. And it's been noted that mutations in P53 and SMAD4 have been found in the pancreatic juice of these individuals anywhere from 4 to 61 months prior to the obvious diagnosis of a pancreatic ductal adenocarcinoma. And perhaps there's an avenue for early intervention and detection. Finally, I just want to talk about pancreatic cysts. So Pancreatic cysts show up in all shapes and sizes, and typically, this is a single isolated 2-centimeter cyst here in the neck of the pancreas. Down here is an MRI showing multiple small cysts seen throughout the pancreas. And this is becoming a bit of an epidemic from the perspective of being found in asymptomatic individuals who are having CT scans or MRI scans. People have quoted kind of up to rates of 40% of imaging studies, but certainly in single digits. There's a long list of a differential that's associated with a pancreatic cyst, but the one that we're actually worried about are these IPMN or mucinous cysts, these intraductal papillary mucinous neoplasms that probably account for the vast majority of patients with asymptomatic cysts. There's two broad types. There's a main duct type, where it arises in the main duct pancreas with a very, very high rate of malignant degeneration and considered a surgical disease. But the more common perplexing disease are these branch duct IPMNs, where they arise in the branch duct, these small cysts, and these still have a yearly 1 to 2% rate associated with them of malignant degeneration. So they become a real diagnostic challenge and management issue, because the rate is real, it exists, and we're constantly trying to figure out, well, which patients should we send for surgery, and which patients should we just continue to follow, because they continue to have their malignant risk. Obviously, if there's groups of patients that have what are called high-risk stigmata, if they've got jaundice, if they've got a very dilated pancreatic duct or a solid lesion, those ones we're very concerned about malignancy. But there's other worrisome features such as mural nodules, size greater than 3 centimeters, that we actually take a lot more closer value and an investigation of. So endoscopic ultrasound is very useful for the evaluation of these pancreatic cysts. For sure, it has superior imaging in terms of looking at the ducts and the cysts and looking at nodules. But probably also it has a great role in looking at the cyst fluid. Cytology, per se, when we stick a needle in this and look for cells, is very specific but not very sensitive. And we're often very reliant on looking at tumor markers. One particular tumor marker that's used very commonly is something called CEA. So this is in the cyst fluid after we aspirate it. This is a study comparing patients with non-mucinous, non-precancerous cysts and mucinous cysts, and saying, yeah, if you take a cutoff at around 800, maybe you can help predict who has a mucinous cyst. But it's important to note that CEA itself is not useful for making a diagnosis of malignancy in the setting of pancreatic cysts. So over time, a variety of guidelines have come up to try and help us understand which of these cysts we should be following, which ones we should be surveying, with a variety of recommendations based on what type of imaging to use. We're using predominantly more MRI. When we should think about doing endoscopic ultrasound. For example, with the AGA guidelines, it's for 2 of 3 criteria: large cyst, dilated pancreatic duct, suspicion of a solid lesion. Also, how often we should be surveying these patients, because they really have a lifetime risk of developing malignancy if they've got a mucinous lesion, and how often we should be stretching out that surveillance. And then there's been some controversial discussions about when to stop surveillance completely for stability, which a lot of us are still not comfortable with. So how good are these guidelines? And so, this has been a lot of experience expended on these. What a positive predictive value here means is when we say the patient should have surgery and they go for surgery, how often do they have a lesion that was considered worth removing, had an advanced pathology like a high-grade dysplasia or an invasive cancer. And here, it ranges between 50 to 70% or so, which is a lot better than what it used to be. It used to be around 20%, meaning for every 5 patients going for surgery, only 1 really ended up having an advanced lesion. But the negative predictive value is how many times a cancer is not missed. And ideally, we want it to be 100%. And unfortunately, with these guidelines, it's dropping down to in the region of 70 to 90%, which is a little bit concerning. So we're left with issues of possibly unnecessary pancreatic resection still being a problem, as well as missed cancers also being another issue. To address that, then, we've looked to biomarkers. And, sorry, that should do it. My own alarm. We should look to, tells me to wrap it up. My own phone telling me to wrap it up. So I'll wrap it up. So we're looking to biomarkers to try and understand if this can help us. This is one particular panel of biomarkers or methylation markers that we're asking the specific question, could we separate out low-grade dysplastic lesions from high-grade or invasive cancers? And this is looking very promising using these two particular methylation markers being more sensitive than either the clinical features that we were following or existing biomarkers, which is very useful. Another exciting item that's coming down the pipeline is the use of endoscopic molecular imaging. This is the use of contrast-enhanced ultrasound with microbubbles. This thymocyte differentiation antigen is a specific marker found on the blood vessels of pancreatic ductal adenocarcinoma. It's found to be found in high percentages there and to less so in normal or chronic pancreatitis. And this, the work of Jürgen Willmann, who tragically passed away recently, was able to demonstrate very high imaging specificity and the ability to pick up very early 1 to 2 millimeter pancreatic ductal adenocarcinomas. So I believe this may be a way forward for finding some of these early lesions as we look to the future. So in summary, we are not recommending general population pancreatic cancer screening at this time for the reasons that I've outlined. Diabetes clearly represents an opportunity for pancreatic cancer screening. We have to see what sort of avenues that will take us in. For high-risk pancreatic cancer screening, it should be performed in high-risk individuals. We have our own CAP study open. There's other studies open around the state that you're familiar with. We are trying to find these advanced precursor early PDAC lesions. We're predominantly using a combination of MRI and endoscopic ultrasound. But really, the outcome and the long-term benefit of these surveillance programs has still to be proven. And finally, we are realizing that for so-called low-risk branch duct IPMNs, that there's a very high disease-specific survival rate, and we're beginning to follow more and more of these patients and avoid surgery. But we are confident also that we're going to have better techniques to clearly identify which patients should have surgery and which patients can be surveyed. Thank you.